Good afternoon. Good afternoon to all of you, and welcome home to Hopkins. You alumni, you faculty, staff, students, and friends of the Johns Hopkins University School of Medicine, and welcome to our afternoon Alumni Symposium. My name is Julia Haller, and I have the tremendous honor of serving as the president of your Johns Hopkins Medicine Alumni Association. The Johns Hopkins Medicine Alumni Association plays a vital role in supporting the School of Medicine in many ways. We raise funds to provide stethoscopes and white coats to both our MD and PhD students. We grant funds to support student and trainee-led projects. We offer financial support to student and trainee groups, and we support student emergency funds. We also, and very importantly, organize Reunion and Alumni Weekend, and thus we are all so delighted to host you this weekend. These next few days offer a full slate of activities. There will be opportunities to connect with old friends and make new ones, to learn about the latest research being done at the School of Medicine, and to celebrate all that Johns Hopkins Medicine has to offer. Today we'll have the pleasure of hearing from a very special panel facilitated by Dr. Roy Ziegelstein, our dean over there of education, and we'll enjoy a talk from our special keynote presenter, Dr. Selwyn Vickers. I'm sure you'll find the insights shared to be both informative and inspiring. I'm excited to see what the future holds for Johns Hopkins Medicine. With the continued support of our alumni, I know we can keep achieving great things. Now it is my pleasure to turn the program over to Dr. Ted DeWeese, who is the Interim Dean of the Medical Faculty, Chief Executive Officer of Johns Hopkins Medicine, Professor of Radiation Oncology and Molecular Radiation Scientist, and most importantly to us, a tremendous advocate of our alumni and our Alumni Association. Dr. DeWeese.
Julia, thank you very much for that kind introduction. Welcome everyone to the 2023 version of our research symposium here at Hopkins. And as noted, I have the great pleasure of serving as the interim dean of the School of Medicine and CEO of Johns Hopkins Medicine. I have been at Hopkins for many years. I may have mentioned this at another venue earlier this morning. Some of you were at. I was a resident here and then a fellow in the lab here and been on the faculty here, and I can say without equivocation just how much those of us who are alums later than you in this role feel so proud to have you as alum of this school. The groundbreaking work that you did, the trailblazing paths that you put forward to allow us to move forward, and I just want to say thank you on behalf of the entire School of Medicine for what you've done. You've carried the mantle of Johns Hopkins at many places in your careers, and you've shown much great light on our name elsewhere. So for you, let me give you a round of applause. Thank you for all you've done. Hopkins is a fantastic place. I am the chief Kool-Aid drinker of the organization, and I'm very proud to say that. You know, what we do is based in that discovery mission, training the next generation of leaders and translating it into the best of clinical care. And they then turn into the alum that are the world leaders like all of you. And we're very lucky, as Julia said today, to have one of those with us today, Selwyn Vickers. Selwyn, as we all know, is an alum, an esteemed, frankly, alum of this school. Trained here, renowned pancreatic surgeon. He learned here, of course. And has gone on to be the dean at University of Alabama, Birmingham. And then most recently, and as I told him as he entered, very lucky for those of us in the cancer field, is now the president and CEO of the Memorial Sloan Kettering Cancer Center in New York, the esteemed cancer institution in the country. Selwyn, it's really a pleasure to have you with us today, by the way. We'll hear from him soon. So with that, I thought, and I was asked to just very high level, very quickly, because we'd rather get on to the speakers of the day, just give you a sense of where we are and what we're thinking about here at Johns Hopkins and in the School of Medicine. When I entered this role now a year or so ago, there were really 5 things that I wanted to focus on. This is the, again, highest level, but they really revolved around the things that you see on the slide, which are making sure we are engaging the community, the people with whom we live and work here, the place that Johns Hopkins himself said we must care for the sick and poor of Baltimore. That is our DNA. I wanted to be sure we were attacking that with greater vigor, making sure we were listening to what the community members needed from us here, not just in terms of access, but the equity and health that they needed. So that was a top priority for me. Also, making sure across what we do at Hopkins that we had the right voices and the right people at the table, a diversity of opinion in our research dialogue, the educational platforms that we put forward, and of course in our clinical care and administrative decision making, making sure we had a diverse group of people and to drive that to a greater degree than we have historically had here. Advancing our mission means many things to many people. That is, again, predicated in large part, as I'll say again, on our discovery mission, driving great patient care and the training of the next generation of leaders. We're doing that in several ways, though, because we need, I believe, to be much closer to the patients that want to come to Johns Hopkins. They all can't be here, so we are moving out into the community in a greater way than we have done from southern Pennsylvania all the way into northern Virginia. Of course, that also means that research discovery base. We are going to be continuing that effort around our precision medicine efforts. How do we diagnose and therefore more accurately treat patients than we do today? And so, of course, the last 3 years in particular has been very challenging on the workforce in medicine. There's a lot that we have to do and need to continue to do to support the workforce that we have. We understand what we do for them here, but they all have personal and other lives. How do we continue to support them so that they will want to stay with us at Johns Hopkins? So supporting the community, many things I could say is I want to just reiterate that point I made, that Hopkins said to us, we will take care of the sick and poor of Baltimore. That is still who we are and what we do, particularly in this hospital. I don't want you to ever think that will ever leave us. If you ever read a little bit further in his document that he sent to his trustees, Johns Hopkins, was that the leaders of Johns Hopkins, the especial people, I've never used that word in my vocabulary enough, especial, that he said it was especially important that the leaders select physicians and surgeons of the greatest skill and the highest character. And so I fully embrace that notion that was given to us all those 130 plus years ago. We must do that. We will continue to do that. But of course that means different things now because we have such a broad impact in our community. So that isn't just with physicians and surgeons. Of course, it's across all the things we do. And I just put 2 things up because I thought they were so impactful in a very kind way. Our Johns Hopkins Home Care Group, that group that goes out with durable medical goods, cares for people in their homes, they decided just to come together. And over the last about 8 months or so have provided, now this number is quite low, it's closer to 2,000 lunches that they would bring along to some of the folks that they see that needed it. It's on their own money, their own time, and just package in to start to, again, care for the people that we care for through our work. And our healthcare group, this is our 4 insurance companies, that arm of Johns Hopkins, decided that they would all pull their money together, and they provided 3 $20,000 checks, grants to 3 important organizations, the Franciscan Center, which cares for a lot of the people suffering from homelessness in Baltimore, the Maryland Latinos Unidos, I think they call themselves, Maryland Latino Unidos, for our Hispanic population, primarily down towards Fells Point area, particularly those who are in need of dental care. And then, in fact, to the Chase Brexton group, which does provide a big base of that care for our community. So just 2 examples of how our broader, not just physician community, but our broader Johns Hopkins community is caring for those that we found most vulnerable. So diversity, equity, and inclusion. We have many, many initiatives on this point. I just want to point out we've crafted a new equity statement, and the thing that's most important to me in the equity statement is found up towards the beginning, which is we're going to continue to deliver on our diversity, equity, and inclusion platform across the tripartite mission. It isn't segregated into we're just going to work on more diverse candidates in our student body as an example. But no, it is across the platform so that all the voices are seen and heard around the table and can contribute to the research platform, to the research questions that we ask. How do we deliver care? To whom do we deliver care? What does our insurance products look like? How are we making sure that's equitably provided? So that's extremely important to all of us, and that's one thing that we're pushing forward. Some of you who saw the last, were in the last session will note that the person who stood forward, sort of ramrod straight in many meetings I was in the conference room, was Levi Watkins on the principles I just described a few moments ago. Yep, thank you. And Levi meant a lot to a lot of us. I think many of you know that he passed away, I guess now about 7, 8 years ago, something like that. But his impact has really never left us. Again, the principles that I talked about, and it's been so important to us to continue to recognize him in multiple ways, the most tangible of which in the future, on June 9th, the Johns Hopkins Outpatient Center, which is just right behind us here, will now be renamed Levi Watkins Outpatient Center to, again, perpetuate those things. And I'm quite looking forward to hosting that event. I noted that in advancing our missions, I've already said it now twice, I'll say it again, Johns Hopkins is the first research institution we're founded on doing discovery that changes the human condition. That's what we do, and that gets translated into the best of patient care. And if we do that well, our students, our trainees, our residents, fellows are learning in the best possible environment. That needs to continue to be our North Star. It was when you were all here, it will continue to be. That's what we put forward. Now, having said that, of course, I was the first of a few that suggested that the U.S. News and World Report rankings, I had much consternation and castigation of them because what they do doesn't really reflect what a student might want to select for a medical school. It's primarily other attributes. That said, I knew some people were interested, so that's where we have landed. Originally, they thought we were going to be the #1 medical school, but as Roy knows and knows more than any of us here, how the surveys are done and it's a complicated algorithm. We ended up being #2 medical school. You can see across some of our biologic sciences programs how they ranked. And then in terms of our clinical specialties, you can see #1 in internal medicine, anesthesia, surgery, #2 in OBGYN, 3 in psychiatry, radiology, 4 in pediatrics. So still doing fine. I love you. I need to have you come to every single talk. I really would appreciate that. But of course, to support that platform of work, we need the facilities to do it. We have a multi-year plan around the infrastructure that's going to be required for it, the most proximal of which, if you happen to march up Monument Street, where the Brady Building used to be and the Children's Center used to be, there's going to be a brand new 12-story contemporary research building in place with 3 wings, 2 of which are basic science, 1 of which is wet bench or dry lab space for analytic kinds of space, the first wing of which will be opening in about a year from now. So that's very exciting for us, and much more to come in that front. Patient care, we could go on all day about that. I think the one thing I wanted to note is because it's so important around the equity piece that we talked about. So during the pandemic, you all know how much telemedicine, televisits became a staple of how we tended to manage patients. And that's kind of waxed and waned a bit since then. But we remain around 15% of our visits are by telemedicine. Most importantly, and I'm really very proud to represent 2 of our faculty, Brian Hasselfeld and Helen Hughes, because they have been the champions at the federal level to maintain access for patients through this modality. Why is that so important? Because our own data proved the patients who benefited the most by this might not be the ones you think. It was patients on Medicaid and underinsured people who most benefited by this. They were the ones who accessed it the most and that the care was most influenced by it. So hopefully the new legislation that Johns Hopkins has helped to support will be continued. Thank you. I noted that we need to be closer where the patients are. Why do we need to do that? Well, of course, they want to come see us. But we have clinical trials that they might want to be a part of for those who have complicated diseases. They can't easily get here for it, so we need our clinical trial platform to be nearer to them. Of course, some of the patients we see will have very complicated care that requires tertiary and quaternary management, so they'll come back to Baltimore for that kind of care. And of course, not the least of which, our surgeons, our proceduralists need to be supported by volumes of patients, and so Baltimore is just not that large a community. Washington, D.C., Northern Virginia is about 2.5 times the population, so it just helps to continue to support the academic missions that we have here. Lastly, I talked about the complexities and stress of a workforce these days. Over the last year, we've continued a project that started a year before, providing small micro grants, if you will, to faculty who have ideas of how could they help their colleagues de-stress, find respite during the workday and on off work hours. And so a lot has been done in this regard. You can see we've just this year put over $100,000 into this, and it's made, I would say, real differences. I don't think it's advanced us to where we need to be, but I think it has kept the lid on the boiling pot, if you will. And I put these up just to show a few of our leadership changes and appointments recently from your left to right. You can see where they've landed. In particular, the second one from the left is Dr. Danny Muschlegel, who has been just recruited. He'll start in September as our new director of the Department of Anesthesiology and Critical Care Medicine from Harvard Medical School. So with that, I will stop, and I think we are now moving to Dr. Vickers. No, Roy. Let me get Roy. So introduce Roy Ziegelstein. I think many of you know Roy from here before. Roy is just the stellar Vice Dean for Education that we have. Roy is responsible really in large part for the outstanding students that some of you met here, make sure we have the right recruitment strategies to bring them here, and the educational platform, faculty and resources to educate them in the way that you all came to be educated. And Roy has continued that tradition. We have a stellar group of students and trainees, both in the sciences and in the medical school, and I just want to thank Roy publicly again for all you do for us, Roy. Thank you very much.
So I want to just tell you what we're going to do, and then we'll do it, and then I'll tell you what we did. So we're going to have a very brief 10-minute discussion about a really important topic, and I'm sorry that it's only 10 minutes, but that doesn't diminish the importance, and that's about wellness of our student population. So I'm first going to introduce two panelists. First, Taylor Evans, if you could come up, Taylor, and have a seat. Taylor is one of our PhD students, but I'm going to have her sit wherever you want. And maybe, Taylor, you can just briefly introduce yourself. I think so.
Is it on now? Yes.
Yeah.
Hi, everyone. I'm Taylor Evans. I'm a fifth rising sixth year in the School of Medicine PhD program, cellular and molecular medicine. I'm also the outgoing president of the Graduate Student Association, which is the body that represents all PhD and master's students, and acts as a liaison with the administration representing that population.
And she was an outstanding president, that I can tell you. And Frances Callahan, could you please come up and introduce yourself? Make sure your mic is on.
Thank you. Hey everybody, Frances Callahan. I am the clinical manager of two of the services that support student mental health here at Johns Hopkins. One is the Johns Hopkins Student Assistance Program, which serves students at the School of Medicine as well as students at many of the other schools, and also a new team, it's about a year old now, the Behavioral Health Crisis Support Team, which currently is conducting mobile response on and around the Homewood and Peabody campuses, but we are coming here to the East Baltimore campus over the next couple of months, and we'll be fully operational here as well. Nice to be here.
Thank you. So our third panelist, you'll see from the picture, is actually not here. She's actually not well. And so I'm going to stand in for her, and I'm going to talk to you about some of the things that she has done. This is Kathy Chrétien. She is our Associate Dean for Medical Student Affairs and also a new title, Director of Medical Student Wellness. And I'm going to tell you some of the things briefly that she's done. But first, I just want to set the stage. You all know, because you've been through it, that being a student, medical student or graduate student, is a stressful experience. That's not new. It is particularly a time of great stress because it's very demanding, rigorous programs, as you know. And also there's a lot of social and financial stress on our student learners. So that's not new, although I think some of the aspects of the stress may be a little bit more intense now than they were 20, 30, or 40 years ago. The second thing is that things like mental illness, substance use, and burnout are really on the rise and are in greater proportion among our student population than, I don't mean our student population, among graduate and medical students than among age, cohorts, among the same age cohorts. That's important. I think that some of you may have heard of the word burnout when you were students, but I never did. I didn't even know what it was. And now we talk about all of the burnout among practicing physicians and practicing scientists and researchers that these students have to interact with. And then third, on top of that came this thing called COVID, which was devastating. And I don't know about all of you, but I think that in the times that I think of when I have been able to help a student in a crisis, I've been able to tap into my own reserve of health. And early in the pandemic, I had no reserve at all. It was so incredibly stressful for all of us, and I think this was a unique time when emotional stress was present throughout, and the people to whom the students were turning could not actually tap into that reserve. So I'm going to sit down next to Francis and ask a few questions. Watch. Let's see. Good. So first, I want to actually just talk about what Kathy Chrétien has done for the medical student population, because I think it's quite amazing. In her role as Director of Medical Student Wellness, she's done a lot of things to make it, I'll say, safe and comfortable for medical students to come to her and to the other assistant deans in the Medical Student Affairs Office to talk about their stress, whether it's financial, social, mental health issues, and so forth. And then she's created a lot of events, typically in the evening, where she will have faculty come and talk about their own mental health problems. This is incredibly raw and emotional discussions. It could be, in addition to faculty, it could be residents. It could be other students who share their own experiences with mental illness. And that actually, I think, in a way, makes it safe and more normalized to talk about these very, very challenging issues that our students face. And then she's brought practicing clinicians, including some exemplars, people that are brilliant, who talk about their failures when they were medical students, when they were residents, and when they're faculty. Errors that they had, and they talk about how they dealt with it, and that's very, very powerful. The students just really are moved by hearing the people that are their mentors talk about their mistakes. And maybe none of you in the audience here have had mistakes, but boy, I've had my share, and it's very easy to think about them and hard to talk about them. Taylor, could you talk about what our graduate student population has in terms of supporting wellness and mental health and emotional health?
Yeah, that's a great point. So I think the graduate student population isn't all that different probably from the medical student population in their needs and recognizing that wellness is kind of holistic from a financial, mental, emotional standpoint. So I know a lot of students reach out to the UHS mental health and all of these programs that are available for students to seek help, and then to have the administration be able to listen to issues when they arise, or us being able to talk kind of freely about the needs of students. I know I've sat on some interviews for therapists that are targeted towards specific populations of students that maybe don't feel like they have someone who understands them, and that's been a great ability for me and representing the population to be able to get these people in to see people that they can relate to, maybe more than just your generic therapist. So that's been really great. I know from the financial point of view, the graduate student emergency fund that Julia was speaking of has been really helpful. We can't always predict the things that are going to happen to us or what our financial needs might be over the course of our graduate education. So this fund has been supported through the Alumni Association to a part, and allowed students to ask for funds for emergencies that happen in their life, whether it be illness, whether it be some sort of educational need, et cetera, that helps kind of reduce burden on students too, not feeling like they don't have support in times of financial hardships.
Thank you, Taylor. Thanks very much. Francis, can you talk to the group here about some of the support systems that are in place for our student population in particular, and maybe how COVID has affected our students and how we're coming out of it?
Yeah, so the word that first comes to mind for me when I think about how people are feeling right now, and that would obviously include students at the School of Medicine, is tender. Really tender, worn, tired, and vulnerable in that way. And so it's been incredibly important to find ways to make it easy for them to access services in terms of the mental health services. And so how that's happened is partly as a result of the pandemic. I think we all know that we learned to meet people on Zoom and in a variety of ways. And that has been, in many ways, a real blessing, because it's just opened up access to people who might not have had time before to come to an appointment or might not have been conveniently located. We also had to think about the fact that many of our students were no longer in Maryland, or no longer in DC. They were around the country. So we had to find ways to provide them services, considering all of the licensure laws and so forth. So we contracted with a partner who allows us to provide psychiatry, scheduled counseling, and then call anytime and talk to a counselor kind of programs anywhere in the U.S. So that was important too. And also, at the other end of the spectrum, we found how important it was to be with people in person. And so what we've experienced with this behavioral health crisis support team that is on its way here to East Baltimore is the power of a human being showing up in person to somebody who's in crisis. And when I say crisis, I don't mean that they have to get over a certain bar. It's not up to us to define the crisis, it's they define the crisis. And we go to them, and it's a partnership between public safety, who takes us there and makes sure that the scene is safe, and then we go in and lead, the clinical team goes in and leads a conversation with the students. And it's been amazingly well-received, very moving experiences that those of us who have the privilege of working on this team have had. And so very excited to be coming to East Baltimore. To be clear, we help anybody who's within our reach. So we actually already have come to East Baltimore and done some crisis response, but our access line is going to open up 24/7. It's actually the only program in higher education around the country who's doing this 24/7. It is popping up here and there at other schools, but they haven't been able to quite staff up to that level yet. But we are, for the past year, 24/7 operation coming out in person to support people. And that's been really important as well.
Thanks, Francis. And I did promise people that we would be brief, so I have only one other question for you both. Some of the people in attendance here have had the pleasure during this weekend so far, I know it's not the weekend, but weekend so far, to meet some of our students, not just Taylor, but other students, and I would imagine that you're blown away by our students, right? I mean, they're unbelievable. And to think that these students who are carrying on your tradition of excellence also could be hurting, that must really move you, I would think. I'm trying to put myself in your position. So I wonder, can you tell the alumni and others, is there anything that you think that they could do to help? I mean, this is a group that many of whom have, devoted their careers to helping other people. Some of whom they've even gone to developing countries to help people. And the question is, could they help some of our students? Taylor?
Ooh, that's a great question. Okay, so my first thought is, would actually be to ask you all to think about the situations that you have been in your career or your education, and where did you wish that you had support, and if there's a certain instance that you can think of, how can you provide that same support to students who are likely experiencing that same thing now? If there's something that comes to mind, I feel like reaching out to the Alumni Association, who we work with very frequently, to figure out how we can best support students, or Roy, or any of the administration, really. I feel like there are probably situations that are still affecting students today that it could potentially be supporting students with. I can't define that for you all, but as you reflect on your own education, find ways to think about the students who are likely experiencing that now, and if you're willing to offer your time or support in whatever way possible.
Thank you. And Francis?
Yeah, I thought it was really moving to hear about how faculty have been talking to the students about the mistakes they might have made and how they process that. I just think that to enable a student who's in this very intense program and this very intense part of their lives, to help them gain some perspective from all of the years of experience that you've had, I think would be incredibly valuable. So I don't know if there's a way for you to participate in that kind of mentorship, but I just think it would be amazingly powerful.
Thank you. Yeah, Julia.
You know, one of the things we talk about at our meetings all the time is other ways we can help, and this is very exciting, and I look forward to working with you on it. You know, maybe we could be part of the mistakes rounds or things like that, yeah.
For sure, seriously, if, you know, again, I don't know about all of you. As a medical student, definitely there were times when I left the hospital at the end of the day and I thought, I'm just not good enough to be here, and I probably shouldn't come back tomorrow. Maybe you didn't feel that way, but to have people who I respected on faculty, I didn't have those people. Let me change that. I had people I respected, but to have people that I respected and admired and revered admit their mistakes, I didn't have that, but our students do, and it's very, very powerful. So by all means, if that's something that you want to be involved with, please email me, or you can email the Alumni Association. The email is up there, right, Julia? Yes. Okay. Great. So please join me in thanking Taylor and thanking Francis. I promised you we would be brief, and I promised you that I would tell you what we were going to do it, and then tell you what we did. I hope you agree that what we've done is to explain that issues related to wellness are very important today, even for high-functioning, maybe even especially for high-functioning people. And I hope that you understand how we're addressing it, and perhaps even how you can help. So it's now a pleasure for me to introduce our key speaker. You already heard from Ted DeWeese a lot about Selwyn Vickers. As I was coming here for internship in 1986, Dr. Vickers was leaving. Isn't that right? So we were two ships that passed in the night. And I'm sorry about that, because I never really got a chance, therefore, to work with him or know him. But he is, as you heard, a phenomenal pancreatic surgeon, and has really established himself as one of the leaders in American medicine today. Dr. Vickers, again, as you heard, or maybe didn't hear, is from Alabama, and made a lot of his mark in his career at the University of Alabama, where he eventually became dean. So imagine growing up in Alabama and then becoming dean of UAB. It's pretty, I don't know, cool, if that's okay to say. And then CEO of University of Alabama Health Systems, even more cool, it seems to me. And now, most recently, in September, moving to as president and CEO of Memorial Sloan Kettering in New York. So incredibly accomplished graduate of the Johns Hopkins University School of Medicine. Please join me in welcoming Dr. Selwyn Vickers.
Thank you, Roy. I thank you for the introduction. I must insert that the people in Minnesota were disappointed if I didn't include my tenure in Minneapolis, which I had a great time and experience, but certainly my time in Baltimore and at Johns Hopkins was critical in so many ways to my personal and professional formation. So I'm very thankful and honored to be back, always pleased and honored to be back and be a part of the institution. It is an unusual world that I have been in as a surgeon, but one of the first models of this was Dr. Michael Johns as a surgeon who chose to go on and lead an academic medical center and institution. And there will be more surgeons in this role. And in fact, both the CEO of Memorial Sloan Kettering and MD Anderson are pancreatic cancer surgeons. The one at MD Anderson happened to train at Memorial. So I think that will continually be an opportunity and a benefit, hopefully, for those who choose to do so. So the disclosure relates to a drug we developed in our lab in Minnesota and still making its way to see if it can have an impact on patients in pancreas cancer. This picture, all too familiar, really speaks a lot of the history of the organization and having it fortunate be driven in part the medical side by Mary Elizabeth Garrett. You might even argue she should have been in the picture she commissioned of these 4 doctors because she was the one who had the foresight to commission them, but also was the one who had to act as a philanthropist to make sure the full requisite amount of monies were available and able to launch a medical school. And as you know, quietly insisted from day one, Johns Hopkins would admit women to the School of Medicine, which was unusual, and again, a place where the institution has continued to lead. And so it's quite remarkable to see that history and understand the role that she played and how fundamentally she helped change the landscape of medical training and healthcare, in large part because of her willingness to both be generous, sacrifice, and to not necessarily cave in on her values. These individuals, I must show requisite because of the surgeons and the dean. John Cameron has certainly been a mentor and friend for a number of years. He was the first to offer me a job. I may be the only to ever turn down a job offer from John, but he's been a great supporter. And Andrew, his son, obviously is serving in that role, and I suspect by all accounts doing an admirable job. And Ted, you've heard Dr. DeWeese. When people are selected internally, for the most part, their character has been vetted. And so I know that you're in this role because of what the institution thinks about you and what they feel you can accomplish. So congratulations in your role, and thank you for your leadership. I would say in this context that there are a number of leaders during my day of here at Hopkins, and the things certainly as a surgical scientist that I've shared with my colleagues at Memorial and my friends at other institutions where I've served, asking why might a surgeon be in this role? And as I shared with Ralph Rubin, although our field doesn't necessarily promote emotional intelligence, when surgeons do possess it, it's a valuable asset. And if they have that as a part of their DNA, either learned or in some way inherent, what often they can bring is a world that has trained them to do everything in teams, a world that's trained them to not simply hold themselves accountable to process, but execution. And thirdly, a world that's trained them to make difficult decisions on incomplete information. And those aspects have served me well as I've had to try to lead organizations that have been a part of the practice of my care of patients and serving and leading individuals. You saw a picture of Levi, and Levi was a dear friend, certainly a mentor and close friend from my undergrad days because I knew there was some other person from Alabama in Baltimore. And Levi grew up in Montgomery, and in many ways we shared so much from the time in the late 70s, early 80s, where we got to know each other, where he fought for me in medical school, made sure that I had a good chance at opportunity at residency, was surprised that I didn't stay here, but he in the last conversation, Levi visited UAB. I had him visit Minnesota as well when I was chair. And he was touched by the fact that the med school that he could not get into because of the politics of the day was now being led by a friend of his, a mentee of his, who in an era where he could make a difference, particularly reminding himself of the time where in my state in school, if you were an African-American citizen, our state paid for you to go out of state so that you wouldn't have to go to the University of Alabama. And so Levi was, and that's no longer the practice, but Levi was touched by the fact that it was remarkable that things had changed significantly. So that is a bit of the soliloquy regarding how certainly my ties and emotions are so grounded at Johns Hopkins, and it certainly has continually served me well, influenced me as a leader where I've had a chance to do that in multiple places. So thank you as an organization, and you who are alumni made this place up and make it up, and you who are currently faculty, students, and staff certainly continue that legacy. So the rest of my talk will be really about issues of health disparities in clinical trials and what those opportunities might look like. Most of my funding and academic career had two platforms: pancreatic cancer science in the terms of molecular biology and trials, and health disparities in cancer-related area. And what I'll speak about today is in the context of health disparities. So King is quoted that of all the forms of inequality, one of the biggest challenges is the fact that there is often injustice in healthcare. And health disparities are persistent, and they're grown out of multiple things, but it's certainly something that society had as a challenge, and probably one of the greatest challenges of the American healthcare system moving forward. So what does that look like in the United States? Disparities in healthcare are racial and ethnic differences in the quality of healthcare that are really not due to medical-related factors. And so they really are due to a set of social determinants as much as anything. This leader makes it clear that ever since the time that the United States has in its beginnings, disparities have been a problem. And if you look back at probably one of the more credible measures of disparities is that in the early 60s and 50s, women of all color died at the same rate of breast cancer. Advent of mammography, and who have access and who have insurance, disparities begin. You see a difference between the death rate between women of color and white women in that process. Largely, it's by the fact that when you have those socioeconomic standards that separate the opportunity, you often end up in that process of one where you begin to create a world of disparities, and it's existed for some time. Minorities and underserved populations suffer disproportionately in their incidence of rates, and overall nearly 25%. And this chart sort of highlights across the board, again, the challenges as it exists, and you see that issue in particularly breast cancer. Although the incidence is higher in one population, the effect and impact is much more significant in another. And that goes across, obviously, for these other tumors as well. So colorectal cancer, breast cancer, prostate cancer, often of those things that are in the forefront of seeking to try to bring and make a difference. And the drivers for these, obviously, to some degree, are about equity, but they're also about cost and health outcomes. Largely, the cost of managing these patients when not screened appropriately or treated late are significantly expensive. So what's the case for inclusion, if you would, for clinical trials? So America is evolving. It's a country now where 50% of the population under the age of 5 is of minority descent. Greater than 55% of the children born in 2017 were of minority descent. And in a generation, 50% of Americans will be majority minority. In general, you can go to almost 2/3 part of America and you're going to meet somebody who's different. The diversity index is close to 62%. And that in large part means that America is diversifying as a nation, and almost many of these parts of our country, you'll find that diversity is growing. So why is this hard, and why should we do it? We clearly have a history of some missteps. Beginning with my home state, the Tuskegee study reminds us of the practical challenge when men were followed for a disease to understand the natural history in the face of denying them therapy. Similar in Guatemala, women were followed in a similar way for a treatable disease to understand the ability to spread and the impact of that disease. And in that setting, you can also look at our Native American population, and even in our own history, as most of us who were in the cancer world worked and spent years on HeLa cells, never knowing HeLa meant Henrietta Lacks. And I commend Hopkins for really doing all it can to recognize both that history and to rectify that message as well. Well, the challenge as it relates to clinical trials are global. Minorities really account for less than 10% of all clinical trials, and only 3%, 3 to 5% of cancer patients are in general enrolled in trials, and less than 0.3% of them are minority. So it's hard to then get a global fix on adequate therapies when that distribution is so limited. So what often determines these determinants, what often affects these issues of disparities is the impact of social determinants. And social determinants are the circumstances in which people are born, grow up, live, work, and the systems of which they live and the illnesses that they live with. Those issues were probably most pronounced in COVID, right? Because those issues are seen when there was the significant disproportionate death rate of African American and Native Americans and Latinos, because they fit the category of living in high density dwelling, be essential workers, so they didn't have the privilege to do remote computer work. Thirdly, they traveled on public transportation, and they lived with chronic illness. And you take that mixture and mixture with COVID, it's like putting gasoline on a fire. The fact of the matter is, these are the issues that create the determinants of health. And it reminds us that someone's zip code has a greater impact on their outcome than their genetic code. The context of social economic factors, behaviors are critical. They're often more significant than the genes and the physical environment that they see. And the clinical care often is late in the game. These determinants, if you would, span the spectrum of economic stability, income, neighborhood or physical environment, education, literacy, food hunger, community social context of what are there systems to exercise and walk without worrying about attack or harm? And are you proximal to healthcare systems that often allow for access and timely care? Now, if you look at some of these practical areas that affect the outcome of people's lives, there are 2 or 3 clearly related to economics and education. And today, the primary determinant of an individual's health outcome is the education of his mother or her mother. Baltimore is challenged like much of America, 63% African American, and yet the incomes of the households that we've talked about are 2 times lower, the unemployment rate 3x higher, and there are a third of the citizens who, if they went 3 months without a check, they'd have no money, 0 net worth. And if you ask the question about education, this pivotal period of learning to read, transitioning to reading to learn is a fundamental determiner of outcomes. It's used as a determinant of prison rate, high school graduation, income, and survival and health outcome, all based on whether you are able to make that transition. And as you can imagine, in most of our major cities, the data is pretty pronounced, often 2 to 3-fold in the disparities between kids of color and majority kids. This was further confirmed by Carl Alexander, who finished his study, a 30-year longitudinal study of Baltimore City schools. He studied kids from the entire socioeconomic spectrum and asked the question and yet hoped that time would have made a difference. And unfortunately, in that 30 years, kids from lower socioeconomic backgrounds had a 4% college graduation rate. Kids from upper middle income backgrounds were closer to 50%. And so education in itself is arguably a great equalizer. And yet, as a social determinant, it has a huge impact on the outcomes of individuals' progression in life, as well as their health outcomes. Now, there is one institution that's done a nice job of having an impact. Hopkins has worked hard under particularly Ron Daniels' leadership, and I'm sure partnering with Paul. It's taken the ownership, very different than when I trained here, where it was a fearful thing if you were a person of color to come to Hopkins. It is an understanding that Hopkins is a credible citizen seeking to make an impact in those social determinants because it realizes it's the right thing to do, but practically it actually affects health outcomes. Hopkins local, be local, making sure that there are economic opportunities, making sure there are opportunities to hire people who might not have a college degree, encouraging suppliers and businesses, and then taking that next big step, getting involved and providing support and integration into the school system, having the Henderson Hopkins School be a source of where individuals now can train at the highest level. And so that impact demonstrates the roles that academic medical centers can play because there are economic engines, often the largest engines in many cities, to help change that paradigm. But arguably the greatest risk is, as I outlined, is that this disparity runs the risk because of our clinical trials really lacks to represent the full understanding of who America is. And the lack of that representation often can create inadequate care, inappropriate therapies, and often missed targets, if you would, for being able to take care of complex disease. So one of the large grants I had, that was a large U54, gave us a chance to look at that. That grant was called Impact, which was focused on using a model to enhance clinical trials. It, in fact, included 5 institutions. Somehow I missed including Memorial at the time, but it included UC Davis, MD Anderson, Johns Hopkins, and the University of Minnesota. And I think it still has models that work today that we learned from the grant. It represented a diversity, if you would, of people. So UC Davis had the Asian population. Anderson had a significant Latino African American. Hopkins and UAB had a significant African American, and Minnesota had Native American. This was funded for almost 10 years because there was Impact 1, which was the assessment, if you would, of the process that might make a difference, and then Impact 2, which was the implementation of it. So there were qualitative and quantitative assessments, understanding the community, understanding the infrastructure of clinical trials, assimilating data, and then creating a platform to begin to intervene at this last level of web portal patient navigation and clinical trials ombudsman. The navigation method or the objectives really were to have innovative approaches both to educating patients and educating clinical trialists of the value of having those people coming from different walks of life be a part of their trials. Understanding by virtue of just of their background and color, they didn't add a uniquely high risk of not completing the trial or necessarily understanding the material. The model that we used of community health advisors was both, I think, reasonably fundable. In this scenario, it was trusted citizens in their community who did not have to have a college degree, and many did not. But there were individuals people who came in from disparate backgrounds could trust, who could understand, and who could basically clarify issues and concerns that they were not having answered before. These were the further objectives of the community health advisors, and the implementation really led to a number of efforts both in each of the sites of both recruiting the community health advisors, developing the curriculum, measuring the response of training to both the patient as well as to the physicians, their nurses, and clinical trial staff. It included a broad number of cancer areas that we used, and it used a number of tools for feedback to understand what might be necessary to make sure we can move the needle. And this just speaks to the actual differentiation of activities that were necessary based on the diversity of the communities of what was needed. Some related to language skills, some related to further education, some related to basically making sure there was a clear understanding of trial phasing. Largely, almost all of them related to having people who the patient could trust in a world where they often didn't see many people who looked like them. And then to understand also the difference between the observational and therapeutic trials. And so it had a significant impact on both the context of who were referred, who was accepted, and really low numbers eventually of those who were declined. Probably the greatest impact related to the education of the patient, but probably even more importantly, the clinical trial leadership and community. We were surprised at the fixed beliefs that they had about including people of color on the trials and having them now be ready for someone who they might not expect, be fully versant in what that trial might be required of them and offer. And in that process, we were able to actually almost double, if you would, the individuals who actually finished and were retained in the program by virtue of having them be a part of our community health advisor and part of the data collection, as well as informing both the clinicians and the patients. This, in fact, led to a continual rise, and we almost at this time double, whereas I told you most of our centers had anywhere less than 1% to 2%. We were able to double the number of those who were underrepresented in our clinical trials from this study. So in practice, it really was about creating a trusting environment. It was also about educating those who had the trials and who had been investigator-initiated trials to make sure they understood that inclusion of these individuals was probably as important a thing about excellence more so than equity. A trial that is not diverse is inadequate and it's less than excellent. And equity sometimes plays out. But Hopkins has always been about excellence, and most of us have always been about it. And that's the drive for this versus saying it's a nice thing to do. So what's the future of trials? And I think for us at Memorial, I think it's a bright one because I think there are a lot of things on the horizon that will help transform it. For where we are and where I have seen things work, it is hard for AMCs, academic medical centers, hospitals to do this alone. Practically, there is a need for trusted partners. The determinants of outcomes of health and disparities, I showed you a list of social issues that often are not in the mainstream of hospitals and their care. And so if you look at what you need to often pull this off, this paradigm is one that fits that. You need governance, you need some issues around affecting the economics in communities. You need issues related to social policies. You also need to have individuals who are willing to be trusted to help educate and affect different socioeconomic positions. And then you need, obviously, health systems that are willing to engage in those partnerships in order to create access and cultural competent care that gives people a sense of trust and value when they enter the system. This example for the matrix for multiple myeloma shows sort of the Venn diagram and overlap of where the combination of industry, federal agencies, including transportation, education, social services. And in fact, most of the needs that you need to affect the social determinants of health are already available in the community. It's largely one where those are not connected to the patients in need. So this overlap is often the necessary connection for that to move forward. One of our scientists, Fran Gainey, showed one of these, the impact on one of these areas by actually asking the question, how big a deal is it for people to actually be fed and be full to complete their trial activities? And many people coming from disparate walks of life, there is a struggle sometimes simply to make the means end ends meet when it comes to having meals. There's a struggle sometimes because things run late and the schedule that they're on forces them to travel a significant distance, and meals are not the opportunity. France-funded studies showed that if you could actually get people access to a pantry or food vouchers, you could significantly change the completion rate of the trials and outcomes. So we also think clinical trials are going to have a chance to be virtual and even more impactfully internationally. And before I go forward, I will mention that in this idea of trusted partners, for us in the Upper East Side of New York, as we venture in this effort, we clearly need partners. The diversity numbers in our local area are not huge. They are growing in our outer area, and we've developed a number of regional partners where we now can actually add access. We've also, which could be a bit of a shot in the leg, we've also now had the state pass a bill that forces the Medicaid managed care companies to negotiate with Memorial Sloan Kettering. They refused to up until January 23, until a state law was passed. Now, that started before me. Craig Thompson and the leadership started that, and it gives us a chance to make sure the level of care that we provide, we have the ability to provide it to the broadest segment of our population. So as it relates to the next step, we think clinical trials have a chance to be global. We think they can have an impact across the country and across the world. And we think they can be accelerated in large part by taking approaches that include more decentralization, improvement of data utilization, and greater stratification of patients who enter. And this process is a paper written by one of our scientists, Bob Lee, who leads a collaboration with the Bloomberg Collaborative around global expansion of clinical trials, which again will give us an expanse and diverse platform for making that difference. Peter Kingham, one of our hepatobiliary surgeons, has an active trial and cancer program in Nigeria. Regular monthly tumor boards, having a chance to actually take even the low resource areas and make sure there's appropriate cancer screening for breast and colorectal, but also making sure as their opportunities emerge, there are clinical trials that are available for this population. The other factor that are going to affect trials, I believe, really relates to genomic studies. And I will go first to this slide. The NIH MATCH trial, which is the premier precision oncology trial, asking people to enroll, having your tumor sequenced, and then asking the question, are there targetable mutations? You can look at the number of African Americans and Native Americans in a trial that's going to determine the next drugs that are targeted toward many solid tumors. Not quite representative of what we think America looks like. The order of 1%, and it doesn't take a scientist to measure 0. But in reality, we think that one of the studies and many studies that will come forward, and this study from Memorial by Mike Berger, and Mike's study really asked the question, could the Memorial Impact Panel, which has close to 100,000 patients in it now, be consistent with also determining ancestry? And they did that, comparing it to a whole genome sequencing process to confirm that this panel is actually fairly accurate, very accurate, better than nearly 90% accurate of predicting African ancestry, which is going to be important, or European ancestry, or Ashkenazi Jew ancestry, or East Asian ancestry, important to really understanding where are the targetable mutations. And they found, surprisingly, that African Americans have significantly fewer targetable mutations. Now, is that because we're studied less, or is that simply because of the genetics they found? Not real clear. This study is probably at its time being published at the highest rate of African American inclusion of a genomic study in the country, and we're talking at 5%. So we have work to do. It's an important study. Another study in this platform showed that even when you do this, they are factors that end up having African Americans being least to get genetic counseling. So the reason that the data is important here is because the future of our world, I believe, in trials is in silico clinical trials. I honestly believe that we will move to a world where the data that we have, that we eventually harness with either computational oncology, computational biology, and data scientists will allow us to model what a response will be, create a prediction paradigm that will be largely data-driven versus experimental outcomes, right? Not putting 1,000 patients on a trial globally, but assimilating the data from their germline mutations, somatic mutations, assimilating the data from their tumors, and being able to actually drive that understanding. And so that world where we can connect patients to clinical trials, give accessibility with more home monitoring, aggregate that data, if you would, annotate it and analyze it in a manner to drive that, will be able to allow trials to really spread. The reality of the value of those trials will be limited based on who's included. And as I mentioned to you, as technology advances, so does the risk of disparities, right? As our country has shown, when more novel things become available, they become available to select few. And there's probably no more true than in this space of molecular medicine as it relates to precision oncology or immuno-oncology. But this is going to be what our opportunity is. It will be both cost-effective. We have to own the intentionality of inclusion of all people of all walks of life to make sure the data is actually excellent and relevant. Without it, it's incomplete and not its best. This final study I'll show from one of our our head of our computational oncology, Sharab Shah. In simple terms, Sharab, and this is, I would argue, I've said to him, this is like the abacus before computer days, even though this has machine learning as a part of it. But Sharab basically took CT scan data, clinical history, histology slides, other radiological information, immunostaining, genomic sequencing, host sequencing, and ask the question, if I can assimilate that data, use an AI learning program, can I have a greater prediction of who's going to respond to a PD-1 inhibitor and non-small cell lung cancer? And he could. Today it's a crapshoot if we just go, because we give everybody it. He was close to 80% greater, or close to 85% accurate in predicting who would respond to immunotherapy, based just on the assimilation of that data without ever giving a patient a drug. So this will continually expand and be a powerful tool that we will use to define new therapies, to define clearly targeted approaches, both with immuno as well as targeted molecules. Its risk is the fact that it's not inclusive. It will not be as best if we don't make the effort to include all of those individuals who make up America and the broader spectrum of humanity. So I'll end with this, and I believe that, and really the critical part of, as I end this talk, leaders at Hopkins, as I now try to make sure at Memorial, as I've tried to make sure at UAB and Minnesota, fundamentally, don't settle for the status quo when they know there's something better. And we can look around this room and look at leaders, and I think of John Cameron, who clearly started a world where people just died from the operation in pancreas cancer and believed there was something better. Likewise, in what we're talking about disparities, there is something better for our country. In fact, that inclusiveness will be better for us all. Having been from Birmingham and actually studied fairly closely MLK's letter from a Birmingham jail, there are 3 principles, even though it was long, that really apply, I think, to us for our future. One, he argues that we're all inextricably linked in some way or another. What affects one person directly will eventually affect somebody indirectly. So to think that you can suffer and have your position not affected by the suffering of others is probably not significantly clear thinking. Secondly, he felt laws that were unjust were no laws at all. He clearly believed that the idea of injustice anywhere was a threat to justice everywhere. And probably what frustrated King the most is as he looked on the opposition he faced in Alabama, it was very clear and it was very transparent what Bull Connor stood for. And he could actually put that in a segment and move on with life because he understood his position, didn't agree with it, but it was clear. But what challenged him the most was the silence of his friends and the inaction of good people. People who had good intentions, good hearts, but were more comfortable with the status quo and the order of the day than to pursue something that was better and excellent. And so that's the challenge for us. It's been obviously the ethos of this institution, whether it's in the realm of what I've shared with you about it impacting the community, but probably at its core it has impacted the transformation of healthcare and suffering in the world, because people here have thought there was something better and have pursued it in many ways. So with that, thank you all very much. Thank you.
Incredible.
Thank you.
That was really incredible. Wow. What a thought-provoking talk, and I know all of us feel like it gets to the very core of who we are, Selwyn. We're so lucky to have Dr. Vickers around for the rest of the afternoon. We have our very moving portrait and awards ceremony, which is following rapidly on the heels of this one. But I hope everyone will have a chance to take him aside. There's going to be a feeding frenzy, I predict. So many really exciting thoughts and so many opportunities, I would say, as well as challenges for us all. So thank you all. I think you've seen in the symposium that the legacy of your Hopkins education and training, and that of mine, is in good hands, and we can really be proud. There's no place else like it on the globe. So thank you all for participating. Dr. Vickers, thank you again. A hand for Selwyn Vickers.
Thank you all. I appreciate it. It's been a great evening. Thank you.